I don't want to be told to just do this thing because I know it's the right thing for you. I want to understand why. I want to understand what the options are, the alternatives considered. I want to be able to make that decision for myself.
It's taken me a lot to be able to trust doctors that they're really understanding me and willing to listen.
Just being two human beings, exchanging experiences and working together as a team, I think is what will make the difference. It's that teamwork.
In this module, we offer a more detailed look at the assumptions underlying the traditional medical model and how changing our paradigm to the independent living model opens up new possibilities for designing care systems that meet the needs of individuals with the most complex needs.
I was trained in the typical medical model, and we were taught that patients would come to me, they would come to my clinic, they would come to my exam room. I was the expert. The patient was a supplicant, hopefully grateful, who should comply with treatment. All of the processes in the traditional medical model were designed for my convenience and not at all for the needs and challenges faced by people with disabilities.
Given these tenets of the traditional model, we might think of it as the we know best model of care, and it's this aspect that we need to change.
That we know what's best for you approach. It's always going to be out there unless you're willing to speak up and challenge. The way to do it is sit down with the person and ask them what they want to do. Most cases, people will tell you that really is the epitome of self-determination.
In Module A, we took a deep look into the barriers that prevent people with disabilities from getting the care they need in the traditional medical model. At a fundamental level, all these challenges stem from an inability to understand how that person lives day to day outside the healthcare setting, and how changing the culture can make drastic differences in their ability to get care.
I began to see that the way we provided medical care was at cross purposes with what was needed for people with disabilities to live their lives. In contrast, an independent living model was developed consistent with human rights that had an entirely different set of principles, and it demanded a change in the medical model approach. Let's compare. In the medical model, disability refers to problems of individual people. In the independent living model, disability refers to problems of societies that fail to accommodate differences. In the medical model, the solution is medical treatment. In the independent living model, the solution is to make communities and life's opportunities accessible. In the medical model, healthcare providers are viewed as competent experts and principal decision makers. In the independent living model, the individual is viewed as knowledgeable about his or her own care needs and a full partner in decision making. In the medical model, the patient's role is to cooperate. In the independent living model, the individual with disability is a self-advocate, empowered and accountable. In the medical model, the emphasis is on acute and restorative care. In the independent living model, the emphasis is on quality of life. Finally, in the medical model, the goal is safety over self-determination, and in the independent living model, the goal is a self-determined life with the dignity of risk.
The attitudes of the independent living model is that people should have choice and they should be able to have a voice, be able to speak, about what it is that they need and they want to get well.
We can share information, we can provide information, but ultimately we need to be listening to that individual, their values, their goals, what they're looking for, and support them in their decision.
You got to be your own best advocate, and you've always got to understand what they're talking about so you can make an informed choice, and that no one should be treated with any kind of lack of respect or dignity, because everybody has a right to live their life the way they want to.
I remember one instance where one of our patients, who was a fairly vulnerable woman with a progressive neuromuscular disorder, who was in the emergency room, wanted to go home. And the emergency room staff was recommending against that, wanted her to stay, to be admitted, to be safe. And our physician went down and said, no, she wants to go home. She can go home. I assume responsibility. That exemplifies the role that you can play in advocacy. I mean, I heard about this instance from this woman for years. That level of advocacy, that level of trust, that level of, belief in her and her right to decide, and the knowledge that our team would be available for her was priceless to her.
How do you create an organizational culture that fully supports the values of independent living? This philosophy has to be infused throughout an organizational culture in hiring, orientation, and in ongoing training and coaching among team members.
I was really the first interviewer for all of the clinical staff. And one of the things that I wanted to do was to really express carefully our philosophy, what population we served, what our approach was to care, because I wanted to make sure that anyone who was even contemplating joining our practice understood from day one how we approach things, what our expectations were. During orientation, we do try to incorporate the voice of consumers. We do try to give people as much exposure as possible to the disability community, either visiting the independent living site, going out into the community with a more senior clinician. We had to recognize that this was a learning experience for most people. Coming from a more traditional healthcare system, whether it's a hospital or a traditional primary care system, coming to our practice was really a culture shift.
Shifting care to reflect these values certainly is challenging if the principles of dignity of risk is not to ring hollow.
Part of the benefit, I think, of our team meetings was team support. So it wasn't only care directed, but it was also directed at caring for our team members and really giving them an opportunity to voice their frustrations, their concerns. And there was one nurse practitioner who was clearly frustrated that a patient she was following was just not following her advice. And her question was, how can I get her to do what I think is best? And our approach to her was, how can we get you comfortable to accept her decision?
With this new knowledge and experience, our primary care practice evolved considerably. Today we have a language for that we didn't have in the past: person-centered care. It also became very, very clear as we evolved this practice that primary care had to be significantly financially resourced to a far greater degree than was seen virtually anywhere. To provide real person-centered care, to provide responsive care in the home, and to provide continuous care through all settings at all time, the practice had to be truly interdisciplinary. Physicians, nurses, nurse practitioners, social workers, behavioral health clinicians, physical therapists, occupational therapists, and critically important non-professionals such as personal care assistants were all part of a team with shared decision-making.
In this module, we have explored how to create a culture that supports person-centered care for people with involved disabilities by articulating how the values of independent living differ from those of the traditional medical model, recognizing and drawing on the expertise of people living with disabilities, infusing the values of independent living throughout hiring, orientation, and ongoing training and coaching, understanding some of the challenges that can arise in shifting organizational culture. In the next module, Module C of this series, We examine the design features that are necessary to put the values and principles we've discussed into practice.
Having a disability may limit your physical abilities. It does not limit your potential to dream. It does not limit your desire to live a meaningful life, to have hopes and desires. And with just a little bit of help, someone with a disability like me can continue living out those hopes and dreams just like everybody else.